Our last topic in this section deals with atrial fibrillation. It's also called AFib. This condition stems from ectopic focus anywhere in the atria, in which the atria acts as the pacemaker. Like atrial flutter, atrial fibrillation is caused by rapid-firing circuits in the atria. But what happens during AFib is that a multitude of impulses spread through the atria and bombard the AV node, all battling for the chance to be properly conducted. As a result, the atrial muscles fibrillate or quiver and create disorganized, rapid, irregular muscle contractions. In other words, it freaks out. Another way to think of it is to imagine yourself peacefully resting at home after a long day at work, when all at once and without warning,
You've got mail.
Your doorbell chimes, the phone rings, your cell phone chirps, and you hear you've got mail from your computer 10 times in a row. That bombardment of information from multiple sources would probably leave you temporarily confused, and your responses would be uncoordinated and probably not very effective. Likewise, in atrial fibrillation, the patient's atrial contractions are uncoordinated and ineffective, which in turn decreases cardiac output. As with atrial flutter, it is important to observe how the ventricles react to the increased number of electrical impulses in the atrial fibrillation, because a rapid ventricular rate can increase the patient's risk factors. During this quivering state, the blood can stagnate in the atria and clots can form, possibly causing a stroke or pulmonary emboli. Let's look at the ECG characteristics for atrial fibrillation. Rate. The atrial rate is greater than 300 and is not measurable. The ventricular rate may vary. If it is greater than 100, it is uncontrolled AFib. If less than 100, it is controlled AFib. Rhythm. Ventricular rhythm is usually irregular. P waves, none discernible. PR interval, none measurable. QRS, 0.04 to 0.10 seconds. Remember that it's the ventricular rate that is of prime concern. The causes of AFib include the usual suspects: caffeine, alcohol, stress, and fatigue, which can produce AFib in a healthy person. Other possible causes include CAD, acute MI, hypoxia, CHF, hypertension, and valve disease. It is also not uncommon to see atrial fibrillation in a post-operative CABG patient. After carefully assessing the patient, you can begin the appropriate treatment. If the ventricular response is controlled, treat with anticoagulants and antiarrhythmics. If the ventricular response is uncontrolled and the patient is stable, treat with beta blockers, calcium channel blockers, or digoxin to slow the ventricular rate. If the patient is unstable, go immediately to cardioversion. Be aware that this may be a chronic condition for some patients and is well tolerated.